And thanks Dr. Rajiv Chaudhary for giving me this opportunity. So I'll be talking about three different scenarios in a cataract surgery. And we all know that the nucleus has to be removed in the central safe zone. No phaco should be performed in the peripheral unsafe zone. So what we normally do, we nudge the nucleus with the foot pedal position 2, and then we give a little bit of energy to get our tip inside the nucleus in foot position 3. Then bring back our foot to the foot position 2 so that the nucleus is held with a vacuum seal or lollipop the nucleus. Then we break it or chop it and then pull into the central safe zone, and then we aspirate. So what happens in this soft cataract, because the cataract is too soft, as soon as you apply vacuum, either it gets sucked or you will have to keep the vacuum very low. At the same time, EP nucleus is very sticky, which keeps it held over there. You are not able to pull it out, with the result that the nucleus gets sucked into the peripheral unsafe zone. So there is a very simple technique for doing all this. You will never have a PCR. You make a trench. I'll show you this. We have made a trench. Now after making a trench, we rotate it, and once we try to hold this nucleus, we nudge it, go inside, bury it, nucleus is held firmly, separated, and then we try to pull out. We are not able to pull it out because the EP nucleus is holding it. Then again we try it, and again after coming out to some distance it goes back. So all attempts to pull it, now what has happened that the tip of the nucleus are already eaten away. So now if I try to remove it, I'll go into this unsafe zone, and over there slight vacuum and you will have a PCR. So now I'll show you the another part where what I'm doing over here, I'm close to the capsular access margin, and with a vacuum setting of 100, 200, 300, 400, whatever it may be, it is okay. I'm trying to remove the EP nuclear plate between the anterior surface of the nucleus and a capsule. So that the EP nucleus which was holding it back, I have removed it just by suction. So once this EP nucleus plate is removed, you will see that this nucleus comes out very easily. So simply remove the EP nucleus plate between rim of the anterior capsule and the anterior surface of the nucleus, then you will be able to pull the soft nucleus at 80 vacuum setting. And there are many methods because I got to cover 3-4 topics. The same technique you can adopt at any time. You feel the nucleus is not collapsing in between, or even in the beginning of the surgery, the cataract is very soft, you can remove 273, 300 degree soft EP nucleus, and then you can collapse whole of the nucleus and remove it in toto. So this technique can be applied at any time. Anyway, whenever we are talking of the mature cataract, we know that there is a chances of runaway rhexis. So the initial is, usually this rhexis, sometimes when you puncture it goes away, then you can't help it. I mean, they are helpless about it. But sometimes when you go, say, beyond a 4 millimeter zone, suddenly you see that it has run away. So we have a tendency to do it in one go. So there are many methods. So you can have a double rhexis, triple rhexis, a spiral out rhexis. So there are many methods described. So this is just I'm showing you where we have done a very small rhexis, and then we thought this may not be safe to do the phaco. Then we make little larger rhexis where the phaco can be done. And but once we remove this nucleus, and after putting the lens, we feel the rhexis may be still small, and capsular phimosis may bring it too close. So you can have the triple rhexis in the same patient, then you can enlarge the rhexis even afterwards. So initial small rhexis just to prevent sudden going out of the in a mature cataract, running off of the rhexis or getting a tear. So this is just, we are using a, at that time we had no actually dedicated capsular access forceps. So this is a borrowed ILM pilling forceps from a posterior segment colleague which you can use. But this becomes a little difficult to use from the side port. So now I come to the hard cataract. You need to have a very high vacuum setting and a very good power setting so that you don't push. And very important to use the very long chopper and use the regular tip. Don't use micro tip. Don't use micro tip. That's very important because the hold will be very poor in a micro tip. When you use a regular tip, the hole will be doubly strong on the same vacuum setting. So we do this rexus, and after doing rexus should be a little on the larger side. That means when I say larger, it should be around 5.5 millimeter. Definitely not less than 4.5 millimeter in any case, so that you can make it well. I have not done any hydro, so the trench has to be wide, because when you want to go to the depth, which is very thick, so the sleeve keeps on getting obstructed, you are not able to reach to the depth. So if the wrench is in a V shape, because the tip and sleeve becomes a V, so if you make a trench in a V shape, when you rotate, your sleeve will get accommodated very easily. So it has to be V on the top, it has to be V at the depth also, so that you can reach. So after making a good trench, if you do the hydro dissection beforehand, then the nucleus keeps on rotating when you are trying to push it. So in a very hard cataract, I do not do hydro in the first part of the trench, because 80-90% of the trenching has been done. So I inject a viscoelastic before withdrawing my probe, my tip out. I inject the viscoelastic. Now I am doing the hydro. So now I'll do hydro dissection. Hydro delineation is not required, but this whole part is nucleus. And after doing this hydro, then I rotate this nucleus, and you will see that once we rotate it, the wider portion will come sub-incisional, which will be able to accommodate the sleeve very well. So we rotate it, and the another important point is that the central part, initially the hardest part is not the deepest part. So suddenly you will see that certain chunk has disappeared, you start seeing the bright reflex, then you come to know that the toughest part you have broken. And many of these patients, even when the nucleus is broken, the part of the epinucleus, or what we call as a leathery plate, that becomes very leathery, which you are not able to break. So the central part of the, in this case also the same scenario, the nucleus was divided, but there is a posterior leathery plate which is very difficult to break. So I'll show you my technique how to do it. So split it. When you try to split it, you can see that the periphery is getting pushed, and you will unnecessarily damage over there. So now what I do is, at a vacuum setting of 600, I'll just hold one end of the heminucleus at the corner where the crack is starting. Now this is a 600 vacuum, and now I pull it with the chopper and split it like this. So like we used to do in a rexus, tangential. So now one fiber is broken at a time. When you try to do it this, you're trying to break hundreds of fibers in one go. So slowly and slowly you see that it starts splitting, like Bhima pulled the leg of the Duryodhana. So same way you pull it, separate it apart, and now rotate it. Do the same thing, repeat on the other side. Hold with a high vacuum setting of 600. Go there, separate it. Once you get two segments, the rest of the surgery is very easy. Try to make smaller fragments. Always try to put the chopper where you want to have a separation. Don't try to keep on pulling away. So keep on focusing, and make a rotation like this. You'll be able to pull it out, and then bring them. Chopping I do, because as long as the nucleus is in the capsule of fornices, there is no chances of PCR. So don't be scared. Use 600, 650, maximum vacuum is available. But as you keep on removing nucleus fragment slowly and slowly, and the nucleus back keeps on become empty, at that time you keep on lowering the parameters. So when you are doing phaco aspiration, my first fragment is at 600, then 550, then 500, 450, 400. So by the time I reach the last fragment, my vacuum settings have got down. Chopper from the sharp I have shifted to the smaller chopper. I put on a viscoelastic to make the capsule safe. So thank you for this, but the basic is phaco tip setting should be very high. The tip should be large. Incision should be as posterior as possible without cutting the conjunctiva. Cysts should be larger, particularly in front or closer to the nasal side where you are going to do the chopping. No hydro initially. Wide and deep trench, because the energy used for making trench causes no collateral damage. It is only when you are delivering close to the cornea it will cause damage. So absolutely don't hesitate using extra energy, and divide the nucleus into small pieces, and initially use a long chopper, then can go to the small chopper away from the cornea. Make a conscious effort to all the phaco should be done away from the cornea. The day I decide, irrespective of the hardness of cataract, if I decide that this patient should have clear cornea next day, that patient will have a clear cornea next day. It is only when you be little lethargic and be little careless, you develop the corneal edema. Thank you very much.
Thank you, HARBANSH, for nice videos on the soft cataract, mature cataract, and you made a job easy.